long sort of block, but I would like to review, as you see, causes of spasticity and the management. Of course, this has several different causes, and stroke will be one of them. So, of course, I will focus on stroke spasticity, but I will also give you overall overview of spasticity and its implications for the patient's quality of life. So what is spasticity? So it's a motor disorder, basically, which is characterized by velocity-dependent increase in the passive resistance to passive manipulation or muscle tone, and which also has increased muscle sort of a tone, increased reflexes, which is basically hyperexcitability of the stretch reflex. So it's really always part of the upper motor neuron syndrome, as you know. Sort of more modern and more contemporary definition would look at spasticity as a sensory motor control problem, which again results always exclusively from the upper motor neuron lesion and presents as an intermittent or sustained involuntary activation of muscles. So this involuntary activation of muscles would interfere with the function, and that's the reason we might consider treatment. So even if you think spasticity as a one single phenomenon, actually it really encompasses three major features. One is intrinsic tonic spasticity, which is increase stretch reflex or hyperreflexia, and also increase muscle tone. And there is an interesting phasic spasticity, again, which is basically hyperreflexia and clonus. Many of these patients would have sustained clonus. And it can also be more widespread, which they would classify as extrinsic spasticity, which is all the flexion and extension of spinal reflexes. So a lot of these patients would have complex patterns, which I will go through later on, which again would be essentially misbalance between flexors and extensors as one way. And so there are some really predictable patterns, which also would help us to decide about their treatment and management. So the pathophysiology again results from hyperexcitability of the alpha motor neuron, which is the lower motor neuron, and because there is a reduced inhibitory input. So really that's the disruption of different pathways. I'll show you the next slide which pathways are really mostly involved. Also, we increase denervation supersensitivity, so we can really think about denervation of these muscles, shortening of motor neuron dendrites, and then collateral sprouting of dorsal roots efferents. So again, this is a really chronically shortened muscles, which can then experience further increase of muscle rigidity. So we have two areas on this slide. So on the right side, you would see the supratentorial control. When you think about corticospinal tract or pyramidal tract, actually very old work with experimental lesions, which is a purely pyramidal tract, actually would cause hypotonia. However, it's a pyramidal tract is not only corticospinal tract, it's actually kind of mixture of descending pathways, and especially innervation from pontine reticular formation and medullary reticular formation and lateral vestibular nuclei also provide some tonic control, and so they are mostly in red. And so these, when they are sort of really hyperactive, that would really actually increase the activity of the alpha motor neuron. So on the left side, you see the lower part of the stretch reflex when you tap the tendon, and so basically again it would be result. So it's really a result of the hyperexcitability of the lower motor neuron or alpha neurons. So also important to think about when you think about damage to the upper motor neurons, it has sort of positive components and negative components. So I would first look at the negative components or negative aspects, which obviously would be motor weakness, which is obviously the main problem of the upper motor neuron lesion is the motor weakness, and also then resulting in a loss of dexterity and loss of selective motor control. So that's mostly what, what these patients, are really limited by, again, weakness and loss of dexterity. The positive component, including increased reflexes, increased muscle tone, and even spastic dystonia, are what I would call them double-edged sword. So spasticity, when you think about spasticity, it's not only detrimental, but also can provide some additional support, especially, let's say, for weakness. If this patient is mildly spastic, mildly spastic in quotes, it can actually provide some support for the motor weakness. So we want us to be very careful when we kind of think about reducing spasticity, that again has also some relatively positive aspects, and so the functional balance needs to be really strongly considered. Another slide. So the clinical, but also there is additional component to that, and this really chronic changes in muscles and tendons, patients who have, and joints, of course, so really resulting in contractures, shortening of the tendon, and fibrosis of the muscle, so atrophy of the muscle and fibrosis. So that's actually long-term consequence. It's not only the weakness, but also these muscles are structurally different, and so there is a quite ongoing research whether early treatment of spasticity would really reduce this delayed sequela of spasticity. So contractures, of course, don't happen overnight, but if one leaves these patients untreated without any intervention, that's probably the most significant, and that's almost irreversible. Of course, I will show you some potentials for orthopedic treatment, of spasticity, but the idea would be to prevent these contractures and other long-term sequelae from happening by early and aggressive treatment of spasticity. So again, if you think about spasticity, it's really resulting also in abnormal posture of extremities. And again, as I said, I will show you very typical patterns which can be expected. Either would be stroke, traumatic brain injury, or other spastic syndromes. And there is also, in arms, you see this flexor synergy, so shoulder flexion, abduction, internal rotation, elbow flexion, wrist flexion. So it's really this misbalance between the flexion of flexors and extensors. And same thing is happening in leg extensor synergy. So it's mostly flexors for the upper arm synergy and extensors for the lower leg, for the lower extremity, with the hip, knee extension, and ankle and plantar flexion. Again, I'll show you specific patterns, and we'll go through specific muscles which are really involved in these abnormal patterns. Before we go on, it's also how do you assess? So because we talk about that this is spasticity is a velocity-dependent increased muscle tone, so you can grade that. But so it's not only says, it's not only question is spasticity present, yes or no, but there are different ways to really grade that. So it's a semi-objective finding, and so probably methods, and that gives you maybe more insights about severity of spasticity, and of course can help you to monitor the treatment. So probably most widely used scale is, of course, MSA, a modified Ashworth scale. The modified is that to the original scale, you see in the table different grades, that 1+ grade was added. So that's difference between modified Ashworth and the original. So this 1+, and again, it's a little bit in eye, or rather in hands of beholder, because you are really assessing the resistance to passive manipulation, and it takes some practice. Of course, if you go from the bottom of the table, 4 would be basically contractures, so we can really move. We are talking about passive movement, not the active movement, but the passive movement. And of course, then 2 and 3 would be probably most commonly seen in our patients, where 3, again, it's some grading and takes some practice, but again, those, usually grade 3 or 2 would be most likely to benefit from this therapy. So again, we would call grade 2 as a marked increase, but you still have a full range of motion. while in 3 you still can get a full range of motion or nearly full range of motion. So it's important to know the range of motion for each segment or each joint you examine. But it's kind of, it's more difficult to do. Again, you would still have that clasp phenomenon when you may have a sudden release of muscle tone. So again, it's good to be, even if you don't do that routinely, at least being aware of this MSA. And again, this is relatively, I would call it the gold standard at this point. And any kind of many times actually, it's important for documentation of the improvement of the treatment. Especially that's the reason to be more aware of this grading scale or assessment of the muscle spasticity. There are some additional more sophisticated, again, we don't have to go through everything. Tardieu scale, which is a really probably almost exclusively used by PNMR colleagues, but I think it's also just to give you idea about other different tools. And this is actually really taking it takes Tardieu. I've been trained and certified, and I don't like it because it's extremely tedious. But basically, you use a different speed of manipulation. Again, coming to that original definition that spasticity is a resistance to passive manipulation. So you first stretch the segment as slow as possible, and then you get basically when you kind of assess the angle. So you have to really measure the angle. So again, this is kind of more. Again, you can mostly use PNMR, but just to be aware. And then you go very fast, and you really see the angle of the catch. So it's really, you can calculate the difference between so-called V2 and V3. Again, we don't have to go through full description, but just again to be aware if you see some notes from even physical therapists, so you at least know that what they're talking about if they use Tardieu scale. There are some additional components, so there are also functional assessments. I didn't really include them in this talk, again, but you can do different tasks, so they are all standardized, and but you can do it sort of more in a sort of not random fashion, but limited fashion. You can ask patient to, hold a cup or hold a pen, hold a ruler, hold a toothbrush for upper extremity functions, and you can get a better assessment. So again, it's actually several tools. Again, you can use broom, toothbrush, I commonly use comb, and so on and so forth. And that's actually coming more to the functional assessment. So because really that's the key, you want to really improve the patient's function. So when we look at this etiology of spasticity, again, as you recall, this is essentially any lesion of upper motor neuron. So really, central nervous system has a relatively stereotypical way to react to the injury. And when I say injury, I don't mean necessarily traumatic brain injury as a mechanical injury, mechanical trauma, but any kind of lesion. So again, stroke, of course, is on the top of the list, but we of course, cerebral palsy is for the pediatric colleagues attending this grand rounds, multiple sclerosis, TBI, spinal cord injury, diffuse anaphylaxis injury, and a lot of neurodegenerative conditions. It also, if you look at the etiologies, also you can really then assess whether you would be talking about focal or segmental spasticity versus generalized spasticity, which also will be important for your assessment of the therapeutic plan. So what's the frequency? Currently we think that it's about 35% patients with a stroke, even though this may be an underestimate. Actually, there are some new studies looking at that, and we sort of see kind of a tip of the pyramid. But but even if you think, let's say, if you take this value at as a final 35%, so slightly 1/3 of these patients, looking at the frequency of stroke, this is still a lot of patients, and many of them don't get a treatment. So again, even though it's not every patient, but again, looking at the incidence and prevalence of stroke, and again, us being in a stroke belt, close to be sort of a buckle of the stroke belt, we are talking in a considerable number of patients. I mentioned cerebral palsy. Of course, this is not the major focus of this talk, but again, really, this is one of the definitions. and essentially 90%, the other ones would have more dystonia or choreiform hyperkinetic movements. Traumatic brain injury, of course, again, it's very variable, but half of these patients would have also usually focal spasticity. Spinal cord injury, of course, so that's also very common, even though that depends on the level. Of course, there can be different patterns, monoplegia, paraplegia, quadriplegia, and of course, multiple sclerosis. And again, you probably see the biggest, variability in the numbers. And again, that really comes from the sort of pathogenesis of multiple sclerosis, having remitting relapsing disease, and different segments can be affected. Again, our main goal today is to focus on the treatment of spasticity from stroke, but has to be said that this is more symptomatic treatment, so you don't have a necessarily different approach between, let's say, focal spasticity from stroke versus TBI. So I will kind of look at the sort of more general principles of the treatment. So what are the consequences of spasticity? So what is the impact of these disorders? And we are kind of coming to the core of the problem that, why do we even talk about treatment of reflex, which, again, as I said, can be many times helpful, can provide patients some support. But of course, it impairs mobility. It can be painful. It is abnormal. We talk about this flexion synergy in upper extremities and extensor synergy in lower extremities. So that can also, because it's immobilized, it can cause pain. And of course, pain can be even more severe once these patterns become more fixed, which again, we want to prevent that. It affects the sleep, mood, self-care, but also, self-esteem. Patient, we see these patients walking with the arm flexed. So, as our office is in a Fraser, so I see these patients on a daily basis. It can really affect quote-unquote appearance, even though I think most patients would be more concerned about the function. But there are some additional areas, fatigue, contractures, sexual dysfunction, increased risk of falls, of course, if it's especially affecting lower extremity, but also caregivers' burden. So if you ask these, caregivers, is it easy to get a shirt or jacket on, or even a hygiene? Actually, the next slide, it's not the best picture, I apologize. So this is somebody, so it's a detail of the elbow. So this is somebody who has a flexion contracture or nearly contracture of the elbow, and basically, if it's sort of always flexed, in a very, very, very acute angle, it's difficult to take care of the skin. And even so, the real goals may be from improving the function, but even can be as sort of mundane as really improving the hygiene. And again, so if you see this kind of skin degradation wounds, that can lead to infections, and of course it's very painful. So there are different levels of needs and reasons to treat spasticity. So as I said, the rationale, of course, is, as I said, is kind of a function, but also comfort. But also, again, so, many times patients who are more affected, if you have more difficulty with transfers, if there is abnormal posture. But again, I think that the third sort of box is the most important. We have to really think, why am I doing that? What is my expectations? So, and that's why we'll talk about goal settings. Again, goal settings is a little bit, we are getting, sometimes wear two hats. It's almost like PNMR. And of course, we are neurologists, but I think that having this sort of wearing this functionality hat, you don't have to really have the breadth of expertise of rehab medicine doctor. But again, thinking, what am I trying to achieve? And that's, of course, is so important that you don't have any unrealistic expectations, or other patients don't have, expectations that, let's say, you treat their spasticity and their arm will be quote unquote normal. They will be able to, let's say, write or things like that. Sometimes it's possible for mild lesions, but again, thinking from wearing that functional hat really gives you, good, am I going to treat that? Can I make it better? And how do I monitor that? And again, so this is just a sort of a reiteration of what I just said, setting goals of treatment. And again, so it's, patient's goals, functional goals, and technical goals. If somebody has a contractures, I don't think I can do much about it. You can sometimes excuse me, improve the pain, for instance. So, your goals can be quite, lofty and really improve function considerably, but sort of more mundane, really, we saw that wound in the elbow area to really prevent this kind of a skin disintegration and wounds. So it's a very broad sort of set of goals, and tailoring to the individual patients is very important. Again, I always like to involve and engage caregivers because they are many times the ones who provide the care. So, ask them what is most difficult, what is easy to do, and so they kind of sit down and see how you can help that. So if you look at the sort of overall flow chart of management of adult spasticity, of course, triggers and aggravating factors are sometimes, can be used even though that it's not a major factor. But again, that you look at this more, we are getting more into the management area already. And again, think about generalized spasticity. Again, that will be sort of probably more post-anoxic injury, or perhaps some spinal cord injury. Patients would have more, quadriplegic or quadriplegic patterns. And again, we have a focal or multifocal spasticity. Again, the typical example would be, of course, strokes. Somebody has right-sided hemiparesis. You just focus on, again, affected either, upper or lower or both limbs, for instance. Multiple sclerosis as well. And again, so you see, so I will go through, we will go through specific options soon, very soon. But again, if you look at this flow chart, it's almost, you see the first line of therapy for the focal or multifocal spasticity is actually toxins, which I'll be also reviewing in this talk. So again, we'll go through different indications, different options and different indications, what you can offer to your patients. So let's start with oral medications, even though this is, so what are the advantages? Of course, it's non-invasive, and it's not permanent. So basically, so these medications have usually half-life of about 8 hours. Can be effective for some patients, but disadvantages are it's difficult to achieve steady state, and also you may have a lot of side effects, so let's say baclofen or tizanidine, of course, would be drowsiness and hypotonia. So hypotonia and weakness will be potential side effect of any treatment with the spasticity. Again, if you recall, I called spasticity double-edged sword, which again, of course, would be its negative impact would be interfering with the function and mobility and care, but that quote-unquote positive would be providing some support for the weakness, so again, that's why you have to really, I call it Goldilocks. It has to be just right. So if you overtreat the patients, of course, you may actually reduce the functionality. But again, for the oral medications, as you see, advantage would be that this is, reversible. There is nothing permanent, and you just stop the medication. The patient should be in a previous state, in terms of their spasticity. So looking at the typical medication, baclofen is probably still king of the hill. It's actually working on a GABA B receptors. This is, again, I'm talking about oral baclofen. But of course, we also review intrathecal baclofen. Tizanidine is actually it's working through alpha-2 adrenoreceptors on the presynaptic cell membrane. And again, they both can be sedating, so that's something to consider. But many patients may have some cramps at the nighttime, for instance, so it can be very suitable to dose it at bedtime when a patient also can be sleepy and have a better improved sleep. So you can use them you don't have to use them throughout the whole day. Can be also, again, nighttime dosing can be very effective. Diazepam and other benzodiazepines are less common. Of course, there is we know they are fraught with a lot of problems with the long-term use. Again, they are GABA A, and they are kind of more really working on a postsynaptic nerve terminal. Again, there are some patients who may benefit. I use them extremely rare, but for maybe severe cases, probably more so in a neurometabolic and neurodegenerative cases, I would be very reluctant to use it in somebody with stroke, because of course also you may have a cognitive sequel of the stroke. So, and also, baclofen and tizanidine can, impair, cognition, cognitive performance through the drowsiness, sleepiness. Dantrolene is used, I haven't prescribed it last 4 or 5 years. It's a really the one, and this is the medication which can have a lasting, irreversible effect. So comparing to baclofen, tizanidine, any kind of benzos, dantrolene has a potential to have a lasting or permanent improvement of spasticity, which sometimes can be beneficial, but sometimes can be detrimental, because again, if you make these patients weaker, more hypotonic, their care and function is worse. Furthermore, it can also cause LFT elevation, so we have to monitor liver panel quite routinely and frequently. I do it every other month, and at the beginning every month. But again, I haven't used dantrolene for some time. And again, the mechanism of action would be to really blocking the release of calcium from the sarcoplasmatic reticulum, and again, calcium is necessary for the, muscle contracture. Now we are getting to the injection therapies, and again, if you recall that flow chart of the management, the first really line therapy for focal spasticity, which would be very quintessential effect of most of the stroke syndromes, would be botulinum toxin injections, but there are other options for injections. There are also neurolytic nerve blocks, phenol. I don't use phenol, but some of my colleagues, my former colleagues in the multiple sclerosis clinic, still like to do phenol injections. They are quite painful, or ethanol, but phenol probably can be used. Again, it's a more, no, it's not obsolete, that's a bad word, but it's much less used. And again, botulinum toxins have really emerged as a treatment of choice. So again, Botox, of course, is a brand name. So even though sometimes I would use it as a Botox, as a botulinum toxin, but again, I'll show you different toxins. So Botox has become sort of more along the Kleenex or Hoover. So when the basically brand name becomes almost as a sort of overall description of the procedure. So that's how I call my botulinum toxin clinic actually Botox clinic, even though I use other options as well. So advantages, again, there are advantages of injections would be they are not permanent. So let's say toxins, it always wears off. So I call it forgiving. Let's say you don't have a desired effects. You may be slightly overtreated patients. It always comes back, so it's nothing, you don't cut anything, you don't sever anything. And of course, the effects are localized, they are not systemic. So again, big disadvantage of medications would be that they are, if you take baclofen by mouth, it works everywhere. And again, so it can also affect, again, cognition, drowsiness, alertness, and so on and so forth. So clearly the effects of injections are localized, even though you may have a phenomenon of a spread of toxins, so you have to be careful how much and where you inject. But you can have a sort of, if you overtreat patients, you might have a almost systemic botulism kind of picture. But of course, that's a complication. But in vast majority of these patients, you would have only localized effects. That's why these patients have to have a lot of injections into different muscles, because really it works mostly where you inject. So disadvantage is, again, it's not permanent. Again, it's great and bad. So if you toxins, it didn't work, it will come back, but it works. The patient comes, it works beautifully, but it went away. So that's sort of, you have to do it. Usually it's 3 months or 12 weeks intervals. And again, it's so many times if the patient is doing well, but they may feel some sort of wearing of symptoms before the next injections. And of course, botulinum toxins can be also, it's the issue of the cost, even though, of course, a lot of studies show that they are essentially very cost effective. Sometimes they can also induce antibodies, even though with the new neurotoxins, it's becoming sort of less a problem, but they can be neutralizing antibodies. And so that's one of the complications of more long-term use. Again, ethanol, phenol, there's a risk of paresthesias because you really actually try to paralyze the muscle, and also you need to be very skilled in that in injections. So again, we'll now focus on botulinum toxins. So we probably all know botulinism as a sort of clinical phenomenon when one gets basically poisoned. There are actually 7 serotypes, from A to G. Only A and B are approved for clinical use. So we have now currently three botulinum toxin A group, and again it's a Botox, Dysport, and Xeomin. And of course, you also see the generic name, but I will refer to them as a brand name, which is because it's much easier to remember. And of course, there is botulinum B toxin, which is called Myablock. Actually, it's interesting that in Europe and in other parts of the world, it's actually called Neuroblock, which I think is a much more appropriate term, even though I think FDA was very concerned, so it had to be changed last minute to Myablock, which is the botulinum B toxin. But again, if you sort of work somewhere else, you would know it as a Neuroblock. So how the botulinum toxins work? So we have 2 slides looking at that. And again, so the main sort of mechanism of action is that it will block the docking of the so in that box on the left side you see acetylcholine, so vesicle filled with synaptic vesicle filled with acetylcholine, and you have to dock it to the synaptic membrane, to synaptic cleft, and then acetylcholine is released and it can work postsynaptically and the muscle can contract. So there are several anchoring proteins, and botulinum toxins A work. Not sure you can see can see my mouse? But anyway, they work on a SNAP25 proteins, basically, so they would cleave them. And so when you cleave this protein, so the docking of the acetylcholine vesicle doesn't happen. And so you have really, that's how you treat the spasticity. The botulinum B toxin works on synaptobrevin. This is another complex. So again, only toxin A and B are approved for the human use. So this is basically the bigger picture, how toxins work. But the second slide shows us more detailed sort of description of the molecule. Every botulinum toxin has a light chain and heavy chain. So the heavy chain, 150 kilodalton protein, is really the main component, and some of these, so light chain would help to dock the toxin into the synaptic vesicle and get through endocytosis process into the muscle. And so then it's cleaved. So some of these new toxins actually have only heavy chain itself. And a light chain, which again, there is a disulfide bonding, which can be easily, cleaved, can be modified. And so we can have different signal proteins to make it more or less sensitive to different type of the muscle fiber. So the second generation of toxins, I think they are coming, will be more bioengineered. But again, really, all they have in common is that heavy chain, 150 kilodalton protein, which then is basically, released, and then it will cleave the SNAP25 protein as you've seen before. So so what is the effects of botulinum toxin clinical effects on spasticity? Again, it's a direct injection into affected muscles. It takes perhaps 72 hours, but many times I tell my patients it can take up to 1 week to work. But the peak effects happen between 2 weeks and 6 weeks. The very important feature of the benefits would be duration of benefits. So again, we typically have these 12-week cycles. And again, these 12 weeks were sort of relatively arbitrarily chosen from the previous studies, but it's not unusual that the patient will tell you, oh, it worked, but only worked for a month. So, then you can always consider a change of the dose of toxins. So you can consider different muscles to be injected, or you can also consider different toxins be used. Again, it's very difficult to compare different toxins because we don't have any sort of head-to-head studies. Actually, there is one study coming which we hopefully will be part, really comparing directly Botox versus Dysport. And again, there's this idea of, to me, most interesting feature of these clinical effects would be duration of benefit. So again, some of these toxins, especially Dysport, perhaps may have a bit longer duration of benefits, up to 16 weeks, which is basically 4 months. There is a new toxin in the development which can really last, 4, 5, 6 months. Actually, I was a part of the trials in my previous institution. And again, so we don't have to talk about at this point because it's still in development. But many times I ask my patients, so first of all, did it work? Did we meet our goals? As we recall, setting the goals is very important. When did it peak and when did it start fading off? So many times, in a good sort of a clinical scenario, patient tells me it was going great, I didn't have any weakness, but last 2 weeks I felt some more tightness and a little bit less function, which is, relatively good pattern. And you don't want to really a patient to come to their baseline. So again, typical duration would be doing that 4 times a year. But if you can really stretch it from patient's point of view, they count these injections. So if they see me instead of 3 times a day, 4 times a year, which will be every 3 months. If they see me 3 times a year, every 4 months, it really gets them much less injections. So there is a lot of efforts to really make these toxins lasting longer. It's kind of interesting. Some of our practices are really set that botulinum toxin injections, we do it every 3 months, and I modify as needed. So that would kind of really create a unique challenge for the scheduling. But I think that from the patient's point of view, this would be extremely beneficial because, again, of course, they come to the re-injection because obviously they have a good benefits, but it still doesn't come as a cream, as I would like to sometimes joke. And they may have really more sustained benefits from the injections. So actually, the potential side effects would be, of course, weakness. Again, if you look at those cartoons, how you prevent docking of synaptic vesicles with acetylcholine into the synaptic membranes, that would cause weakness. So that's what I call it Goldilocks. Has to be just right, which is sometimes easier said than done. But that weakness is a possibility, and of course you can have a diffusion beyond injected areas, which is probably more important and more about cervical dystonia. As I'm not talking about cervical dystonia, I'm not covering that today at all. But dystonias is also very important and frequent use of toxins. And again, for cervical dystonias, of course, you may have a leak or diffusion, I should say, to the other muscles, which can then cause, let's say, dysphagia. Dysphagia to me would be one of the best example of weakness. But of course, even for the paretic limb, when you really inject a higher dose, patient may feel more weakness and actually then losing that function. Again, it's always forgiving in a sense that it will wear off. And you can always adjust the dose. So that's why really either seeing these patients, around 6 to 8 weeks, or at least getting telemedicine visit, or asking them to keep track of the benefits can help you to decide about the next injection strategy. So it's contraindicated during pregnancy, lactation, and also neuromuscular diseases, especially those with the blocking acetylcholine release. So again, so obviously myasthenia gravis would be best example where basically you would potentially causing catastrophe. So, or any other Lambert-Eaton syndrome and so on and so forth. And of course, but again, this is not very common scenarios. But most of this, but if somebody has had a stroke and has a history of myasthenia, which of course can happen and will happen in some patients, you really you mustn't use toxins. Again, allergic reaction is always a possibility. I never had one, never reported, but again, you have to always warn the patient about this possibility. So I mentioned several patterns, and so this is actually now so this is mostly showing so flexed elbow, flexed wrist, clenched fist with a thumb adduction are the most common patterns in the upper extremity, and those are mostly distally. And let's say if you look at the clenched fist pattern, if the patient has troubles opening the hand, there is no function, but again, it can be also, it's difficult to clip nails or, wash the hand, so it can really, create not only functional impairment, but also could be, again, a question of hygiene. We saw the wound from skin breakdown in the elbow area, but can happen in any area. So these are typical patterns for the upper extremity. And for the lower extremity we have mostly distal patterns here. So flexed toes, plantar flexed foot ankle, or equinovarus foot, which is basically flexion and inversion. Of course, the lower extremities also have additional patterns with the scissoring, so hyperreduction of knees or a flexed knee, but especially for the stroke, I just showing these some more distal patterns, which are most typical seen in a post-stroke spasticity. Other type of spasticity, let's say multiple sclerosis, you may have a more proximal muscle involvement, but again, for the typical stroke sequela would be this sort of extensor synergy in lower extremities. It's important to know which muscles is doing what. So each pattern is relatively predictable in terms of which muscles do that. So look at the flexion of ankle would be gastrocnemius, soleus, and tibialis posterior. Those are most commonly injected muscles. Again, more distal lower leg muscles. Of course, you can also inject additional for the flexion toes would be, of course, flexor hallucis longus and flexor digitorum longus, but also you can also sometimes inject short flexors in the foot itself. For the upper extremities, again, flexed elbow, biceps, brachioradialis, brachialis, pronator teres as examples. So I won't go through every muscles, but that's why it's, you cannot really never run away from anatomy. Of course, I think that EMG rotation is extremely helpful because, this is the way you can really learn to identify the muscles. I won't talk much about muscle identification, but of course you can use anatomical approach. Just really know where of course gastrocnemius or soleus is easy, but if you need to distinguish flexor carpi radialis or ulnaris, so anatomical localization may not be enough. You can use the EMG. You would basically hear the muscle. I actually personally prefer electric stimulation, which is kind of coupled with the EMG, so I can deliver stimulating pulse, square wave pulse to the muscle where the needle is, and if the needle is in the right location, I would see the flexion. Let's say I do flexor carpi radialis, so actually I can see the wrist flexing. Of course, this is more useful for patients who have a less severe spasticity. If someone is a very severe spasticity like grade 3 on a modified Ashworth, you may not see these movements, and so it's getting more and more used would be ultrasound guidance, even though that's much more time consuming and actually need 4 hands to hold the probe and hold the needle. And of course you hold the needle, but somebody holding probe for you, and it's much more time consuming. So again, there are different ways to we can have a talk just on toxins itself with the demonstration of muscle identification, of the guidance. But if you are, for some of these spasticity syndromes, I think that using only anatomical guidance can be okay for many patients, again, especially those who have more severe spasticity. You don't have to remember this, but actually, so this would be sort of, so again, we talk about several toxins A, so I'll show you only dosing for Dysport and Botox. So again, it's different units, so it's important that each toxin, they are not interchangeable, so they are different units, and so again, you don't have to remember this, but typical conversion ratio between Dysport, which is a relatively newer addition to our Botox repertoire, is about 2.5 to 1. So again, most of us train on Botox, which is basically most of us used to this dosing. So again, this is a difference. So you have to be very careful if I use all 4 toxins, and I don't do conversion in my head anymore. I kind of call it almost like speaking different language. I just be speaking Dysport today, and I just know this different dosing for different muscles, versus I will be speaking Botox, which is again the most commonly used. Botox and Xeomin are 1-to-1. So once you know Botox dosing, you don't have to really worry about Xeomin because it's really 1-to-1 ratio. So again, this is FDA-approved muscles, and it gives you the range. So you see for each muscle there is a range. So basically, if you think about above the elbow would be between 200 to 400 units for each muscle, and below the elbow would be between 100 to 200 for Dysport. Botox, again, so this is the dosing for the originally approved muscles, and again, it's about 100 to 200, especially for biceps, then about the elbow, and would be anywhere between 12.5 units to 50 units, or below the elbow. So again, it's kind of getting a little bit annoying. I have to a little bit vent here that some insurance companies require a very detailed plan even before I see the patients. So knowing which muscles are quote unquote FDA approved then helps you to navigate. Of course, you can always modify. You can even inject muscles which are not approved by the FDA in an off-label fashion. But again, this is something what sometimes you need to know when you negotiate or try to get approval. So this next table, again, showing additional muscles. So Botox actually is the longest one, has the longest history of approval for upper extremity spasticity. But there are additional muscles added. So again, brachialis, brachioradialis, again, those would be elbow flexors, and quadratus, and also intrinsic hand muscles, and also flexor pollicis brevis. Basically, those are all muscles in a hand. So you can then really, especially for the clenched fist and abducted thumb, you can really choose these muscles as well. Again, you can do it, on label, off label, but sometimes, this knowledge is helpful because it helps you to navigate the insurance process. So this is the sort of table. Again, you don't have to remember that, but just giving you again the idea for the Dysport dosing for the lower extremity again. So, and you treat gastrocnemius. Each head is a different muscle. For soleus, which is kind of really below the gastrocnemius, and so again, this is just for your reference. Again, you don't have to remember this, but once you sort of start using toxins, you need to know the range and again, which muscles to inject. Same thing for Botox. Again, those are approved muscles, and also you have more anatomical location here. So again, the idea is that these toxins are not interchangeable, so you need to really know the dosing. Again, with a sort of point that Xeomin and Botox are 1-to-1. I didn't go through dosing for MyoBlock, which actually technically is not approved for spasticity. It's mostly for the blepharospasm and cervical dystonia, which is completely different dosing. And again, of course, I can tell you that if you need to do that. But again, we use myoblock, which is type B, for spasticity relatively rare, even though there are ongoing trials for trying to get approval for myoblock and spasticity as well. Again, this is completely different dose in the dosing. But again, I just skip that just to really not to give you too much information to confuse you. But again, the idea is that you need to, again, they are not interchangeable. That's the most important take-home message. Looking at the time here, so very briefly, so let's look at the other types of therapies. Again, I've mentioned baclofen, of course, it's oral medication, but it can be done also delivered as an intrathecal. Again, has the same sort of mechanism of action, but the idea is that it's such a low dose. So intrathecal would really require a minuscule dose. If you took that amount, 75 micrograms or even 300 micrograms, there is really absolutely nothing. You would have no benefits or effects taken orally, and so again, it really has hardly any systemic effects unless you have a failure of the pump, which I'll review in a minute. But again, that's somebody who would benefit. This would be more appropriate for more widespread patterns, but also some patient with a stroke who didn't get toxin benefits or have a more widespread I keep saying toxicity, I mean, of course, spasticity. So this is, again, so you have to remember the dosing, but again, if you think about the conversion, if you use 60 milligrams, would be 20 milligrams orally 3 times a day of baclofen, which is a 60 milligram daily dose. That would give you about 0.024 micrograms per mil lumbar concentration. So it's really a very short half-life. So you need to deliver the pump. So this is kind of a scheme of how the pump is delivered. So basically, the neurosurgeon, mostly neurosurgeon, would insert catheter at different levels. So also you need to then talk to them about what's the level, because the higher you go, you may have a more. So I'm trying to just treat lower extremities, also upper extremities. So the level, vertebral level when the catheter is inserted, then gives you kind of benefits for lower upper extremities. This can be programmable. This is actually old Medtronic. So this is the actual pump, and you see, and Medtronic old, we call it brick. We also, the same program is used for deep brain stimulation, and again, it really allows you to have very fine dosing. So actually, I don't do it anymore. I used to do that, but PNMR provides, perfect sort of services. And these pumps needs to be not only programmed but also refilled. So you have to really have a maintenance of the pump. And again, PNMR can help you here. Before we commit to the intrathecal baclofen, this patient should really have a benefit of oral baclofen and also showing positive screening. So basically, you would pre-treat the patients. You basically perform spinal tap and typically inject 100 micrograms. Sometimes some centers use 75 micrograms, but usually 100 micrograms. And you can basically assess the patients to see whether patients have benefits. Patients who have a so-called cerebral origin, especially those stroke or TBI, you shouldn't really consider intrathecal baclofen, unless they are more than 1 year after the original event or insult. Again, this is the process, so the screening test is important. That if the patient doesn't get benefits of the one-time injection, then you probably wouldn't proceed to the actual surgery. So that's why the patient has some sort of preview of what they can expect. So let me a little bit speed up because we are almost out of time. So again, so side effects would be, again, mostly, so obviously would be headache or dizziness if you have a high position of the catheter. And of course, there can be complication of the kinking of the catheter. You can have a pump malfunctioning. And withdrawal is also, so these patients need to have some baclofen at home and some benzodiazepines, and it can be really emergency. So it's usually handled by neurosurgery, but you need to know that if patient has a baclofen pump, they should have some medications as a backup, should have very unlikely but not impossible pump failure. again, so we kind of talked about it, so let me skip this one. So let me go through the other neurosurgical treatments. And again, so you have the list of potential options. Most commonly is used selective dorsal rhizotomy, which basically you sever, you cut dorsal sensory nerve roots. And you can really, so this is probably more used for cerebral palsy. I mean, I've seen a few patients with a post-stroke spasticity who underwent SDR. Again, it's, you mostly perform in children, but I've seen it also done in adults. But again, this would be probably most used for cerebral palsy, but I think I included this slide for your sort of overview of all the options we have. And so this is basically just the really, you can isolate these, different routes for each nerve. You can stimulate, so you really know which muscle you will affect. And basically, once you cut it, it's done. So there is really no way to go back. So that's basically, so the advantage of SDR is a one-time procedure, and it's effective, but disadvantage is permanent. So if you make patients hypotonic, there is no way to go back, so, and you can also have some sensory side effects as well. Again, it's less used for adults patients, but I think it would be good to know, to be aware of that. So, and there are some orthopedic surgeries which would be mostly, so actually I think I skipped one slide, lengthening releases, tendon transfers. Those are mostly patients if you look at the population from the stroke patients, you don't want to really consider this because, hopefully you'll be more proactive and more successful to prevent that, but it can use, osteotomies, fusions, tendon transfers, releases. They are all, again, reserved for long term, and mostly those who have contractures. So, in the conclusion, going to the sort of kind of looking at the sort of flow chart for the spasticity in the post-stroke patients, again, it's important that you assess these patients, so it can happen. It can start very early, and there are ongoing studies and emerging data showing that the early treatment makes a difference. If you recall, I showed you the slide showing that these muscles become fibrotic, not only atrophic but fibrosis, and actually, so there is evidence that early treatment of spasticity would really prevent this long-term mechanical change in the muscle itself. Again, you should monitor them, and again, for the persistent or progressive focal spasticity after stroke, again, I think that the standard of care and first-line therapy should be at this point really botulinum toxins. Actually, again, so we are going to also expand our offer with Dr. Holiday. So, we will, obviously, you can also refer your patients to our clinic, our botulinum toxin clinic. And again, so it's usually 4 times a year, every 3 months. Again, but of course, patients who have sort of more resistant, or maybe some patients are really needle phobic, you can still consider oral therapies. But again, I would not use them as a first-line therapy. Even American Academy of Neurology, their treatment guidance recommends toxins as first-line therapy. And of course, then you can, if for more refractory cases, you can again do, intrathecal baclofen, and of course, then it would have more kind of multidisciplinary spasticity service. And again, think about function. What is your goal? What is your goal? What do you want to achieve? So this is my last slide, and hopefully a few minutes. And I went a few minutes over, but hopefully a few minutes for some questions if you have any questions. So thanks so much for your attention.
Thank you so much, Dr. Hedera. That was a wonderful review. We are referring more and more patients to your clinic because we do understand post-stroke spasticity needs to be treated early, and I'm glad you brought that out. I hope the residents and other faculty will remember that early treatment with toxin can make a big difference. I know you see some of them who are so terribly contractured that it's very difficult to treat. Can you tell us about the problems you have with those people who are 4 years out from stroke and terribly contractured? What can you do for them?
Yeah. So again, so for the obviously then so that's something you don't want to see, but of course let's face it, we still do that. Sometimes we can still use toxins for these patients because it can help the pain. So botulinum toxin, of course, can be used for migraines. Of course, I didn't go through that. So I still offer toxins, and many patients would have not much improvement in their function, but they may report big improvement in pain. So it's still reasonable to consider that option. But and then this is the time really thinking about either orthopedic procedures, of course, working with the PNMR. But I still think that I wouldn't dismiss toxins again, offer it, and again. But then the goal, I tell them, you won't get a much more range of motion, but your pain may improve. And so again, it's always trial and error. But again, this is probably more patients who you need to talk to orthopedic surgeons, PNMR. But I still give them 1 to 2 cycles of toxin, and many times just pain can be. So it's not a pain medication, but it can, and it's hard to see. So you don't see much change in their muscle tone, of course, the range of motion if there are contractions, but they would report that my pain was much better. So it can be even benefit as sort of, which is very important. They can really then stay away from pain medication. So again, it's something we would like not to see. So this was maybe one of the main take-home messages, that be very proactive, but of course it will still happen. But it still may offer some benefits with the toxins and the medication for these patients.
Thank you. Are there any more questions? This has been wonderful. Thank you so much.
Pleasure. Yeah, enjoy it. Thank you very much.
Bye-bye.